The session we're doing later today is really looking at the challenges that indolent disease faces in terms of the very long survival. So it's a success story, really, in that I'm just about old enough to remember seeing patients with newly diagnosed follicular lymphoma and telling them they had an average life expectancy of around 10 years. That is definitely longer now. Recent series suggest it's at least 15 years, possibly even 20 years, which is great. But it poses new challenges. One of the challenges is how do we make progress in introducing new drugs, perhaps non-chemotherapy drugs? What endpoints do we use? We can't really use overall survival because people are living so long. Can we use progression-free survival? That also has its challenges. And one particular area that I think is very interesting is with the new sort of non-chemotherapy agents, if I can put it like that, that are coming through, such as lenalidomide, such as BTK inhibitors, such as PI3 kinase inhibitors, new anti-CD20s, there's a whole plethora of PD-1 inhibitors. A lot of these drugs, not all of them, but a lot of these drugs are given for quite long periods of time. You know, immunochemotherapy generally is roughly 6 months, and then there may be a period of maintenance with an antibody, but you know, they're relatively discrete blocks, whereas new treatment paradigms can be more prolonged than that. Now, that may be fine, but actually a lot of these new agents, well, none of them are side effect free, and although some of these side effects may only be grade 1 or grade 2 adverse events, which don't particularly look very serious when you see a publication or a presentation, if a patient's experiencing, say, grade 2 diarrhea for 2 years, that's really quite debilitating. In the presentation, I'll give a case story of one of my patients who was on a trial of a new agent who had exactly that, grade 2 diarrhea for some years, which by the end of the time he was on the drug meant he couldn't really leave the house because he had frequency and urgency with the diarrhea. He found it socially very crippling, so much so that even though he was in a complete remission, so his disease responded brilliantly well to the treatment, he had to come off it. So really, I think one of the messages in the symposium is for us to think about how we judge the tolerability of these new treatments. And I think we have to move away from thinking what are the grade 3, 4 adverse events to thinking what are the clinically significant adverse events, even if they're just grade 1 or 2. And you know, a grade 2 adverse event for 2 years is probably just as bad, if not worse, than a grade 3 event that lasts for 2 weeks. So we need to, I think, be thinking about the area under the curve of toxicity rather than the peak toxicity, but that's a different way for us clinicians to think. Another thing though we'll be very much discussing is, are there any surrogate endpoints that we can use to judge success? So again, I've mentioned overall survival is not particularly a good endpoint. Having said that, you know, there's a recent trial in relapsed follicular lymphoma of a new anti-CD20 antibody that is showing an overall survival benefit. So I certainly don't think we should scrap that as an endpoint, but it just means we would have to wait a long time to see it. So there are various other surrogate endpoints that have been proposed. There's the CR30, so patients who are in a complete remission 30 months into their treatment line. That's a very controversial surrogate endpoint. The FDA in the States have suggested they may be willing to accept that as a licensing endpoint. The EMEA have said they're not. So there we have two agencies with conflicting views. MRD, minimal residual disease assessment, could be used as a surrogate endpoint. But how robust is that? It's certainly not easily applicable to general clinical practice. So whereas it's done in trials, and it's important it's done in trials because it has certain biological meaning, you know, should we really be using that to license a drug and to change our treatment paradigms on the basis of that? So I think it's going to be an interesting debate. Another, I think, very relevant endpoint to think about as well is time to next treatment. It's a little bit soft in that some clinicians may recommend treatment sooner than others given the similar scenario, so I don't think it'll ever be used as a licensing endpoint. But for clinicians like us making practical treatments, patients like time off treatment. So time to next treatment actually is a very relevant endpoint and may be significantly longer than the progression-free survival. So again, when we're evaluating trial data and applying it to our patients, time to next treatment I think is a very important endpoint to look at. For a licensing trial, I think progression-free survival is here to stay for a while longer still. Minimal residual disease is a very interesting biological readout and I think has great scientific merit, so I would certainly hope it's built in. I would certainly hope it is built into studies. I don't think it's going to be taken by licensing agencies though as a particularly relevant endpoint. So although these things I think are going to be interesting to discuss, I don't particularly see the field changing in terms of what endpoints are going to be primary endpoints. But I do have a strong opinion about the toxicity. I think we do have to change the way probably we report those toxicities, but certainly how we think about those toxicities. And we need to, I think this is a case in point where we have to bring patients into the discussion. This is obviously a very topical area. The research institutes in a number of countries are very much saying we need to involve patients. Sometimes it leaves clinical investigators thinking, but how does that help? But I think this is one instance where it really does help, where we can actually say to patients, what are you looking for in a remission? What is tolerable for you? Does 18 months extra remission pay off for the slightly increased fatigue that you're likely to experience? There will obviously be a wide variety of views amongst patients, but I think it's important that we have that dialogue.